Okay, hello. Today's lecture will focus on the respiratory system. This is part of Anatomy and Physiology 2, and this will be found in Chapter 21. So let's move ahead. Now, when you look at the respiratory system, it has an upper and lower respiratory tract, and they have different functions. The respiratory system, by definition, is composed of structures involved in breathing. We also refer to this as pulmonary ventilation. Respiratory tract is composed of the conducting portion, which consists of the nasal cavity, pharynx, larynx, trachea, bronchi, and bronchioles. The respiratory portion is the thinnest bronchioles and the alveoli. Now, we've heard of, someone has an infection in the upper respiratory tract or the lower respiratory tract. All right, let's talk about this. When we talk about the upper respiratory tract, we include the nose, nasal cavity, paranasal sinuses, and pharynx. The lower respiratory tract would be referred to include the larynx, trachea, bronchus, bronchioles, respiratory bronchioles, and alveoli. And here you can see the upper respiratory system. So, pharynx, the paranasal sinuses, the nasal cavity here, and of course, the nose. Now, the lower respiratory system consists of the larynx, okay? We have the trachea, we have the bronchus, and eventually we get into the very fine areas of the bronchioles, and then eventually the respiratory bronchioles here, and the alveoli. Excuse me. I also want to keep mindful of several of the nearby structures that can be affected or play a role in the respiratory system, and that, of course, is the diaphragm. We have the ribs. We have also, of course, the clavicle. And behind the trachea, and it's very important, is the esophagus. Now, the functions of the respiratory system include the following: providing an extensive surface area for gas exchange between air and circulating blood, providing air to and from the exchange surfaces of the lungs along the respiratory passageways, protecting the respiratory surfaces from dehydration, temperature changes, and invasion by pathogens, producing sounds for speaking, singing, and other forms of communication, as well as detecting odors by olfactory receptors in the superior portions of the nasal cavity. The respiratory defense system really protects the respiratory mucosa. Now, what is the respiratory defense system? This is a series of filtration systems that prevent contamination. So, the respiratory mucosa is the conducting portion of the respiratory tract. So it's right up in and right next to the lumen of all of these parts where the air passes back and forth. Now, in this respiratory mucosa, you have pseudostratified ciliated columnar epithelium. Sounds like a mouthful, but it's very important. We have what is called the mucociliary escalator. We have the lamina propria, which is the underlying basement membrane, and then the mucus glands. Now, in cystic fibrosis, this is an inherited disease. It creates thick mucus. Also, the failure of the mucociliary escalator occurs, and thereby the individual is subject to increased risk of infections, particularly Pseudomonas aeruginosa, excuse me, which will colonize stagnant mucus. This is found to be caused by a gene defect of the chloride ion channel. To help you to understand this, think of it this way. When we talk about the pseudostratified ciliated columnar epithelium, it's the cilia moving along that move the mucus thin layer along. Particles of dust, yes, smoke is made up of particles, pollen, bacteria cells, even viruses, etc. As they travel down and they come in contact with the mucus, they stick to it, sort of like flypaper. But then the mucociliary escalator will move this material up through the lower respiratory system. In the upper respiratory system, you have it predominantly in the nasal area, and it moves the material out to the back of the throat, where it's either swallowed or coughed up. Okay. So you'll see this here. Here is the mucociliary escalator. Here's the mucus. Now these are mucus cells. We would call them goblet cells. Here is, of course, you're going to have your ciliated columnar epithelial cells. Okay. They look pseudostratified. They are not. Underneath this epithelial cells, you will have the lamina propria. You will also have a basement membrane. You will have stem cells here generating new columnar epithelial cells, and of course the cilia are constantly moving around. Now, you also have beneath this a mucus glands, which will also subsequently supply some mucus as well. I want you to understand a couple of other aspects here. You can see where the debris is moving upward. Now this is in what might be considered the trachea. In the nasal area, the mucociliary escalator moves the mucus down to where it will either be, as I said, either coughed up, swallowed, spit up, whatever. Interestingly enough, certain chemicals in tobacco smoking shut down the mucociliary escalator because they paralyze and stop the movement of the cilia. This helps to account for the higher risk of respiratory infections that smokers demonstrate. Okay. Now, we have here the respiratory mucosa with the mucus cells located up in here. We have in the back of the throat stratified squamous epithelium. That is because the stratification is necessary because what you have is the boluses of food that will push and erode down as they go into the esophagus. In the respiratory mucosa, again, you have this situation here with cilia and mucus-producing cells. As you get down lower into some of the bronchioles, you're going to see cuboidal epithelium. When you get eventually down to the alveoli, it's all simple squamous epithelium. And that only makes sense because you want to have the minimum thickness between what would be the air right here and what would be in here, which would be, of course, you'd have the endothelial cell of the capillary. You want to have the thinnest or least thickness of a respiratory membrane consisting of course, the alveolus cell, the basement membrane, which is fused with the basement membrane of the epithelial cell, and so it can go right into the blood, or from blood right into the air sac. Here is an individual who is taking an aerosolized mixture. This happens for individuals parainfluenza, asthma, individuals who have had certain irritations, and so what they have to have is something that would be a drug like a bronchodilator, etc. This mist allows a lot of the particles of the mist to go down deep into the respiratory tree, as you would say. Now, the fine particles are really solutions including the drugs necessary to cause bronchodilation, and that would allow for better gas exchange. Now, in the upper respiratory system, which I said includes the nose, nasal cavity, paranasal sinuses, and pharynx, we have to note that there are, in the nose at least, structures that exist that are cartilaginous or bone-like. The dorsal of the bone is supported by the hyaline cartilage. You have the nasal cartilages there in the nostrils. You have nasal conchae, which are the turbinates. These include the superior, middle, and inferior. The spaces beneath the conchae are called meduses. Now, all of this is necessary for this olfactory epithelium to lie over on top of it. And the conchae, these turbinates, allow for this turbulence of air as you breathe in, or if you really want to sniff something, so you can sniff it, create turbulent air, so it has the greater chance of exposure to the olfactory sensory cells, okay? The paranasal sinuses produce mucus to sweep the nasal cavity surfaces moist and clean. the nasal septum, which consists of the vomer and the perpendicular plate of the epithmoid. Then we have, of course, the pharynx, which is, of course, divided into the nasopharynx, oropharynx, and laryngopharynx, and then the trachea. Now, the nasal cavity is the opening into the nasopharynx choana. Now, the nasal vestibule, you'll notice there, the bones that consist of the nasal cavity consist of the frontal bone, nasal bones, plural, because there's two of them, the ethmoid, which has its perpendicular plate there, the inferior nasal conchae, the vomer, and the maxillae. You will also note that there is both a hard plate and a hard palate and a soft palate that make up the floor of this nasal area. Then as we move air through the various pharynx structures, we get into the larynx, and we have to be mindful of the glottis. Now, why do we need nasal mucosa? Well, it's used to help moisturize the air, adjust the temperature of the air, and of course, it will act to clean some of the particles that are in the air. The best example I can give you is this. If it's on a really, really cold day, let's say -10, and you breathe in some air, you can feel how it's sort of cold and then it gets warmed up, but as you breathe it back out, it's going to contain some moisture and it's going to be of a warmer temperature. When it hits the really cold air, it looks like smoke. It's not smoke. It's really the condensation in the presence of really cold temperature air of the warmed and more moist air. The particles start to collect and form this kind of small aerosols of moisture. Here is the dorsum of the nose. You have nasal cartilages here. You have the nostrils, otherwise known as the external nares. Now, the point I want to bring up here is this. If you have a break in the nose here, now notice these are the two nasal bones I said earlier. It is going to be quicker in healing than if you have a break down here in the cartilages. That's because cartilage heals far slower than bone tissue. Now, if you do this cut through here, you're going to see, of course, these structures like the eyes, etc. But the purpose of this is to show you the paranasal sinuses, which include, of course, the frontal sinus, the ethmoid air cell, and the maxillary sinus, which is on the side here. Okay, here you can see the nasal conchae. They're sort of like shelves, extensions here, and as the air would flow around them, that is where you're going to have exposure to the olfactory epithelium, which will do the chemical analysis, and it will trigger information. It'll be passed up through the olfactory nerves into the olfactory bulb and then further processed. You'll be able to detect rose smells and geraniums and gasoline, etc. Notice on the lower part here, we have the hard palate, which is composed of bone. We have the tongue. We have that perpendicular plate of the ethmoid, which consists of the nasal septum, and then also what contributes to some of this is also the vomer bone. Now, if we look by a sagittal view, you will see the external nares. You also have an internal nares, which is considered back here, but this is the nasal cavity. Here are the various structures here, the conchae. You'll have the cloaca, which is the passageway going into the beginning of the nasopharynx. We have the oropharynx, which is that area right here, back of the mouth forward. And then we have the laryngopharynx, which really starts around where the larynx is, etc. Notice that if we have food going down, we're going to have to go through the esophagus here, but right next to the esophagus is what is the larynx and eventually the trachea. A couple of other points to note here. The presence of the hard palate, which is bony, the soft palate, which is more fleshy. Okay? And what happens is, of course, at the end you have the uvula, which is sort of folds back as we swallow a bolus of food. So it doesn't go back up the nasal cavity. You will have also the part here, which is going to the epiglottis, which will flap down and prevent food from going into the larynx, etc. Now, the larynx protects the glottis that produces sounds. The structures there are the epiglottis, which folds over the glottis during swallowing. I just mentioned that. The thyroid cartilage forms the most anterior and lateral walls of the larynx. You have, of course, the structures of the cricoid cartilage, the vestibular ligaments, the vocal ligaments, the corniculate cartilage, the tracheal cartilage, and the small cartilages, which include the cuneiform, the corniculate, and the arytenoid. Now, when we get into where the actual vocal cords are, you have the glottis, and then you have the rima glottis, which is the opening between the arytenoid and the vocal folds. Phonation is the term for sound production by the larynx. Articulation, this is speech, and it requires other structures like teeth, tongue, and lips to be coordinated so that you can clearly provide the necessary sounds altered in such a way so that you can understand them. If you look here, we're going to have the anterior, the sagittal view, and the posterior view of the area around the larynx, and you'll notice right up here is the hyoid bone. That's that unusual bone that's not connected to any other bones. You have the ligaments attachments to the hyoid bone, the medial thyrohyaloid ligament. You have laryngeal prominence here, and this is all of the thyroid cartilage. You have the cricoid cartilage here. Now, if you notice right here, a very important structure, a medial cricothyroid ligament. This is the ligament that people use as opposed to digging down into here. You're going to have a cricotomy, where you actually put a small slit into this ligament and put down a breathing tube if someone is having a difficulty breathing. Okay? Here's the point also. Well, why would they do it there instead of what I've always heard is a tracheotomy? A tracheotomy really is going in, punching a hole through here, through the tracheal cartilages. To do that takes a lot more healing after you've removed the breathing tube. It's much more preferable to do it here, where it causes less damage and heals much more quickly than actually cutting through some of these tracheal cartilage rings. If you look on the side here, of course, we have the hyoid bone, the epiglottis, which prevents food from going down into this area we call the windpipe. You have, of course, the corniculate cartilage here, the vestibular ligament here, and then the vocal ligament. So these are what is referred to as the false vocal cords. These are the true vocal cords. You have also the arytenoid cartilage here, the cricoid cartilage here, the tracheal cartilage is noticed here. On the posterior view, you have the cricoid cartilage that comes around, the arytenoid cartilage here, thyroid cartilage here. All right. And as this is taken apart, you can see the small laryngeal cartilages, the cuneiform cartilage, the corniculate cartilage, and then of course you've got the arytenoid cartilage here. This is where we see the glottis. We have the rima glottis, and we have the vocal folds. Okay. Now, the trachea, bronchi, and bronchial branches convey air to and from the lung, gas exchange surfaces. The trachea, another name for it, common name, is called the windpipe. It begins anterior to the vertebrae C6. The tracheal cartilages are C-shaped. The trachealis is a band of smooth muscles that really attaches on the ends of the tracheal cartilages and controls the lumina of the windpipe. The carena of the trachea is the end of the trachea, and it's the last cartilage segment. The bronchiole basically lack cartilage but have smooth muscles. That's where you're going to get into the situation of bronchial dilation by sympathetic activation. So you have the bronchioles expand in the lumen diameter, as well as bronchoconstriction, which is under parasympathetic activation, and so you will end up with a constricting of the lumen diameter where the bronchioles are. If you take a look here, we go from the larynx to the beginning of the tracheal cartilages down to the bottom here, which is where the carina is. Then from there, we go into the main bronchus, right, left, and what you'll notice is after the main bronchus, the next level down is the lobar. Okay. What you will note is you get less and less cartilage, more and more smooth muscle. Here's a point why this is a C-shaped structure of cartilage as opposed to a full ring. Right next to it is the esophagus, and as you know, the esophagus has to expand out as you swallow a bolus of food. Because they are so close to one another, if it expanded, you would literally have a rubbing or friction as the food moves past each one of these rings, which would be detrimental. Rather, to also have the flexibility to increase or decrease the lumen of this trachea, you have the trachealis muscle, which if it contracts, obviously there would be a reduction in the lumen space here. Notice in the mucosa of the trachea, excuse me, you have tracheal glands which will provide mucus. And of course, this is tracheal cartilage. Now, the air conducting passageways in the lower respiratory tract go from trachea to main bronchi, lobar bronchi, segmental bronchi, bronchioles, and then the terminal bronchioles to the pulmonary lobules. As we can see from here of course is the carinae. We go into the main bronchus, the lobar bronchus, you notice now instead of having rings, you're having more what they call cartilaginous plates. You have the visceral pleura here. You're entered into the left lung. You get down to now the segmental bronchi until you get eventually to the bronchioles. In the bronchioles, you will have a respiratory epithelium, and you will have a ring of smooth muscle. No longer will you have any cartilage. You have to have the flexibility by the contraction or relaxation of the smooth muscle to alter the diameter and thereby alter the airflow going from the bronchioles to the respiratory bronchiole to the pulmonary lobule. The lungs have lobes that are subdivided into the bronchial pulmonary segments. This is where we get into what we call the bronchial tree, which is a branching pattern of bronchi and bronchioles. A bronchiopulmonary segment is a segmented bronchus that supplies air to a specific region of one lung. When you look at the gross anatomy of the lung structure, you have the apex and the base. Now, you're going to have lobes and fissures. Lobes, for the right lung, you have a middle, an inferior, and a superior. Basically, you have 3 lobes. That's because you have 2 divisions, 2 fissures, oblique, horizontal. Yet on the left lung, you only have 2 lobes, superior and inferior, and that is because you have only one divider there, the fissure of the oblique. The cardiac notch. This is basically on the left lung along the medial margin of the left lung. And you can see it. Here's the cardiac notch right over here. Here you can see the various bronchopulmonary segments for each of the lobes. Right superior lobe, right middle lobe, right inferior lobe. Here, left superior lobe, and then you have the left inferior lobe. This is the apex, this is the base. You can see this on this cadaver image. The superior lobe, this is all right lung now. You have a horizontal fissure here. You have an oblique fissure down here. So you have inferior and middle lobe. Notice, and if you remember when we did the heart, 2/3 of it stay off from the midline. So it's kind of pointed over on the left side. And you will note, here's our diaphragm. And here is our left lung, which is basically a superior lobe, an oblique fissure, and then the inferior lobe. And you can see this by this diagram, which makes it a little bit easier to see. And of course, here's the apex and the base and the apex. Now, you have to also understand that there's a certain area where all of the pulmonary veins, arteries, the lymphatics, as well as the bronchus enter, and that is called the hilum, right here, okay? This area would be the cardiac notch, okay, the indentation, okay? Now, the pulmonary lobules contain alveoli, where gas exchange actually occurs. The bronchopulmonary segment will consist of segmental bronchus, the terminal bronchioles, which serve a single pulmonary lobule, and they consist of respiratory bronchiole going all the way to the alveoli. In that area of the alveoli, you'll have the alveolar duct, the alveolar sac, and the alveoli are basically in that alveolar sac. Keep in mind that you have also pleurae. Now, there's a visceral, which is in the outer surface of the lungs. The pleural cavity is occupied by serous fluid. The parietal pleura is on the inner surface of the thoracic wall. And then we have the alveolar epithelium. Now, when we take a look at the microscopic anatomy of the alveoli, we have type 1 and type 2 alveolar cells. They're also referred to as type 1 and type 2 pneumocytes. With the type 1 alveolar cells and the endothelial cells in the pulmonary capillaries, they make up basically what's the respiratory membrane. I mentioned that earlier. In type 2 alveolar cells, these secrete a surfactant, which is phospholipid based. What a surfactant does is it lowers the surface tension along the surface of the alveoli, prevents the air sacs from collapsing. Because what you have to keep in mind is, in all of these very thin, fine sacs, you have a thin layer of fluid, and it's mostly water. So due to surface tension, because this is a polar molecule, you're going to have these molecules trying to pull together, and they can literally close up the alveoli, okay? And so what they do is they add this surfactant that breaks down the surface tension. This is very important, as I may have mentioned in the lab, but what you go through with premature birth babies, those that are premature from 25 weeks up until about 35, 37, they're not making surfactant yet. Now, if it's apparent that this child is going to be born premature, what the doctors do is they bring the mother in, give her a shot of cortisol, corticosteroids, and then as soon as the baby's born, they get again a shot of corticosteroids themselves. The idea is that the corticosteroids will trigger the forming of the surfactant. Now, there used to be other attempts at doing this, including extracting surfactant from cow lungs, from abattoirs. You have to understand how serious this is. Prior to the procedures to handle preemies with the respiratory issues, a premature baby would struggle to breathe, and after about 3 days, they would collapse and stop breathing. And it's basically because of the fact that they could not resist all the forces that were keeping all the alveoli open, or actually all the forces that are keeping the alveoli to try to close. They would be struggling to get air in to those collapsed alveoli. Now, you also want to notice the presence of elastic fibers that surround the capillaries to provide recoil for exhalation. We also have to keep mindful of the blood-air barrier. The blood-air barrier consists of the alveolar cell layer, the fused basement membranes of the alveolar epithelium and capillary endothelium, and then the capillary endothelium itself. Here we take a look at what is the final end here. This is the bronchopulmonary segment here. You have the bronchioles, and then you have the respiratory bronchiole and the alveoli. Now, as you force air all the way down in here, you're going to come to a point where breathing doesn't as much take the place. Instead, what it is really diffusion. This occurs at the respiratory bronchiole and in the alveoli. Okay, so as gases are exchanged here in this alveoli, you basically will have carbon dioxide going outward via diffusion, oxygen coming in via diffusion, and then you will have it passing across the respiratory membrane, which we'll get into in a minute. One of the things to keep in mind is, if you notice here, the branch of the pulmonary artery is right next to the bronchiole. That's because the pulmonary artery, now remember, the pulmonary circuit is reversed. So arterial blood will be deoxygenated. You want it to be reoxygenated at the respiratory membrane. And then as it leaves, it's going to be highly oxygenated, so it's going to go eventually to a branch of the pulmonary vein. Notice also the presence of a lymphatic vessel in this area too. Okay? Now, let's get up close to this respiratory situation here. The blood-air barrier. Right off the bat here, this is the alveolar air space. You have this thin coating of liquid to keep the surface moist with surfactant here. This is, of course, the alveolar cell layer, which is basically squamous, simple squamous in its epithelium. You have both of the basement membranes for the alveolar cell layer and the capillary endothelium, they're fused. Then you have also a very thinned out endothelial cell here. And so you basically have, from air going into the blood, a very thin area for molecules to travel from one place to another. Okay, so from blood to air, from air to blood. Now, let's take a look at the entire setup here of the alveoli. What you see here are pneumocytes, okay, alveoli cells type 1, and these are basically making up the entire alveoli. Pneumocytes type 2, these guys are very important as they produce surfactant to reduce the surface tension of the fluid that is basically covering the entire site of the alveoli. You will see periodically alveolar macrophages, and some of them will squeeze and occupy into the area around or on the alveolar surface. They are to make, and this is extremely important, the alveoli sterile. In other words, no germs supposed to be in there. No bacteria, no fungal cells, no viruses, no nothing. Okay? Keep that in mind. You also have the presence of some elastic fibers around in here to allow for recoil and the elastic flexing that occurs in the alveoli as the lungs expand and contract during respiration. Also, you will notice the presence of capillary here, and the endothelial cell of the capillary is right up here. You can see if you just magnified this little section here, it would look like this. So the air-blood space, or the blood-air barrier, is very thin right here, as you can see as an example right there. Okay? Now, moving on. Respiratory physiology involves external and internal respiration. Respiration consists of external respiration, gas diffusion, internal respiration. This is referred to also as cellular respiration. Okay? The main function of the pulmonary ventilation is to maintain the alveolar ventilation. Basically, to help you to think about this, external respiration occurs at the lung to the blood. Okay? Internal respiration occurs at the blood to the tissue site. Now, we have to come up with several terms here. Hypoxia. This is low tissue oxygen levels. This severely limits the metabolic activities of the tissues. Okay. Anoxia is the supply of oxygen is completely cut off. Here is our pulmonary ventilation occur here. Gas diffusion has to occur between the alveoli into the blood. Carbon dioxide, of course, would leave the blood, go into the lungs. Gas diffusion also plays a key role from blood transferring into the tissues, and this is where internal respiration occurs. And there's a variety of different cells here to give you an idea about what we're talking about, internal respiration, okay? Now, we have to get a couple of gas laws understood as we understand the principles around the physiology of respiration. Pulmonary ventilation is driven by pressure changes within the pleural cavities. The first law, Boyle's law, is saying that P, which is the pressure of the gas, is inversely related to the volume. Another way to look at it is P1 over V1 is equal to P2 over V2 if you've had this in chemistry for gas laws. Basically, the pressure of a gas in a closed container is inversely proportional to its volume. Now, this is at constant temperatures, mind you. Another way to think about it is this. As I increase my thoracic space, that's where I increase my volume, I'm going to decrease the air pressure in my lungs. It will be now less than atmospheric pressure, and as a result, the air will always go from an area of high pressure to low pressure, and so it will follow down into my lungs. Consequently, when I exhale, I relax my thoracic cavity and thereby decrease the volume. And when I decrease the volume, I increase the pressure in my chest, and it becomes greater than the atmospheric pressure, so I breathe out. And I've just said that here. Inhalation occurs when intrapulmonary pressure is less than atmospheric pressure. Exhalation occurs when intrapulmonary pressure is greater than atmospheric pressure. Now, the movements of the diaphragm and ribs cause changes in the thoracic volume. Okay. Serous secretion of the pleural membranes creates a bond that prevents the lungs from collapsing. What do I mean there? If you remember, we talked about the serous membranes, the visceral and the parietal. Parietal lines the chest cavity, visceral is attached to the lung, and between that is a gap, visceral space, that's filled with fluid. Now, this tight attraction keeps the lungs attached to the thoracic wall. If we lose the serous secretion, if we pop air in, air is much more elastic, flexible than liquids. Therefore, putting an air pocket into a lung will cause the lung to begin to separate from the pulmonary or the thoracic cavity, or thoracic wall, excuse me. And so as it separates, now we have what we call a collapsed lung. Now, the direction of airflow is always going to be determined by the difference between atmospheric pressure and interpulmonary pressure. Now, we get into this concept called tidal volume. You don't even think about it. This is the amount of air moved into the lungs during inhalation, as well as out of the lungs during exhalation. In other words, you're not even thinking about it, you're just breathing. Usually that's going to be about 500 milliliters, half a liter. So what's this atelexic? Atelexic is the collapse or closure of a lung resulting in a reduced or absent gas exchange. Many times it's unilateral and it affects part or all of one lung, often called a collapsed lung. When we have a collapsed lung, something has caused that. Something has caused the lung to basically detach from the thoracic wall. A lot of times it's going to be what we call a pneumothorax. A pneumothorax is an abnormal collection of air in the interpleural space between lung and the chest wall. Symptoms typically include sudden onset of a sharp one-sided chest pain and shortness of breath. In other words, think about this, shortness of breath, why? Well, gee, if one lung has collapsed and they're both separate from each other, they're both independent from each other, I've still got one lung giving me some gas exchange. But the lung that's collapsed, I'm going to have a report of a sharp and just on one side chest pain. This can be occurring because of puncture wound, knife attack, bullet wound, any of these type of things. What you have to do is, of course, stop up the wound, but then remove the air. And by removing the air, usually it's with a large bore needle and a syringe. And as you suck back the air pocket from the lung will reinflate and attach itself back to the thoracic, the chest wall. Okay. Now, here is a representation here to give you the idea about the Boyle's law. If I have here a set conditions, no change in temperature, here are my walls, the pressure, the collisions of the gas molecules against the walls are demonstrated as pressure. The total volume here is the volume I would have for my experiment here. Now, if I decrease the volume, that's going to increase the pressure. If I decrease this volume, I'm going to have more of these gas molecules colliding with the walls, creating the increase in pressure. If I increase the volume, greater than this, obviously, what's going to happen is now I have decreased the pressure. There is now more room, but where gas molecules move around and will not bang against the walls, and thereby you have a decreased gas pressure. When we talk about respiration, you're going to have several things happen. One is that you're going to have a superior movement of the rib cage. This is going to help increase the depth and the width of the thoracic cavity. In essence, you're going to increase the volume, decrease the pressure within that cavity. When the diaphragm contracts, it tenses and moves inferiorly, kind of straightens out. Notice that you've got here this relaxed state, and now here it's going to tense out, straighten out. This is also going to increase the volume of the thoracic cavity, decreasing the pressure within it. Now, here's where we were talking earlier, and I mentioned this. If the pressure on the outside and the pressure on the inside were equal, no problem. You're not going to have gas going in or out. But notice where you have this thoracic cavity defined, it's by the presence of that diaphragm and also by the lungs being inflated and coming up close to the thoracic wall, because you have a parietal pleura here and a visceral pleura here and the pleural fluid in between. If there is an air bubble here, this will expand and it will literally cause the peeling away of the lung, away from its intimate contact with the thoracic wall, and the lung will begin to collapse. Now, if the pressure on the outside is greater than the pressure on the inside, let's say I've increased my thoracic cavity, pressure is lower here, air is going to come in. The opposite, if I have decreased the thoracic cavity space, the diaphragm, notice, is now up, the ribs have relaxed, the pressure is greater here than on outside, and so the air will flow outward. Now, you'll notice the pressures are measured within the alveoli, and you have the pressure differential. So when I have an inhalation, I have a drop in the pressure, thereby I'm going to have air coming in, and then what happens is then I have exhalation as I relax and allow the thoracic cavity to recoil back, the diaphragm to relax. You have a reduction in the thoracic cavity volume, and so the pressure is going to get greater, and I'm going to have the air leave, and that's the exhalation. There are 4 common units for reporting gas pressures: millimeters of mercury, that's mmHg. Normal atmospheric pressure is approximately 76 millimeters per mercury. Torr, which 1 torr is equal to 1 millimeter of mercury, therefore normal atmosphere is also equal to 760 torr. Centimeters of water. This was in a hospital setting. Anesthetic gas pressures and oxygen pressures are commonly measured in centimeters of water. 1 centimeter of water is equivalent to 0.735 millimeters of mercury. Therefore, the normal atmospheric pressure in centimeters of water is 1,033.6 centimeters of water. Pounds per square inch. Well, normally, this is the pressure in compressed gas cylinders and other industrial applications. They're generally reported in PSI. Normal atmospheric pressure at sea level is approximately 15 PSI. That's the better number is 14.7 PSI. Now, we have to go over the breathing muscles that are involved in respiration. In a normal inhalation, you have elastic fibers in the walls of the bronchial tubes that stretch as the lungs expand. The muscles that you really need are as follows: the diaphragm and the external intercostal muscles. That's it. If you want a forced inhalation, that's where you're going to bring in several other muscles: the sternocleidomastoid, the scalene, the serratus anterior, the pectoralis minor. But this is if you're forcing it. Think about it this way: you're not in physical shape. You go run down here, run up there, and suddenly you're like, you're doing heavy breathing. That's the forced inhalation, and you notice that your body is moving up and down and heaving a bit, etc. That's when you're going to pull in these other muscles to help you. If you're just sitting there listening to this lecture, the only two muscles that you're really having, because you're probably having normal tidal volume, breathe in, breathe out, roughly about 500 milliliters of air, and it's just the diaphragm and external intercostal muscles. Now, normal exhalation is a passive process, and this results from elastic recoil of the lungs. So what I'm saying here is that after you've inhaled, part of the mechanism that allows for exhalation is just this elastic recoil. When inspiratory muscles relax, the elastic fibers recoil, the diaphragm and ribs and sternum return to their original positions. The thoracic volume will decrease, air moves out of the lungs following the air pressure gradient. It will be greater in the chest than outside, and therefore it will flow out. But what if you needed forced exhalation? That's where you're going to have a set of muscles that are going to help to act to decrease thoracic volume in a much more forceful manner. And these 6 muscles, or sets of muscles, play a role. The internal intercostal muscles, the transversus thoraticus muscles, the rectus abdominis, the external oblique and internal oblique, and transversus abdominis. Yes, you need to know these. As you can see here, here are the accessory inspiratory muscles as opposed to the primary inspiratory. In primary inspiratory, external intercostals, diaphragm. The accessory inspiratory muscles, the sternocleidoid, the scalenes, the pectoralis minor, and the serratus anterior. The accessory expiratory muscles, the internal intercostals, the transversus thoraticus, the external obliques, the rectus abdominis, the internal obliques. Okay. And this diagram goes over the basics here. Notice that the primary inspiratory muscles are basically the external intercostals. They elevate the ribs, and the diaphragm flattens somewhat. You're all increasing the thoracic cavity space. When you need to have greater gas exchange, when you have greater oxygen demand, for example, etc., you're going to have the accessory muscles that will assist external intercostal muscles in elevating the ribs, and that's where you see these playing a role. Okay. The accessory expiratory muscles, they're active when needed. You can see them here, and they will play a much more profound effect when you have great demands for gas exchange and thereby really pushing out a lot of air. And that's, of course, because you're going to depress further the ribs, reduce the width and depth of the thoracic cavity, as well as push the relaxed diaphragm into the thoracic cavity further. Okay. Now, pulmonary function tests determine lung performance. This is really important. Now, when we talk about respiratory volumes, there are different approaches. We have the expiratory reserve volume, ERV, and that's the maximum volume of air that can be forcefully exhaled after a normal exhalation. So we have ERV is equal to the EC, which is the expiratory capacity, the maximum volume of air that can be forcefully exhaled after a normal inhalation. And this is minus the tidal volume, TV, which is the amount of air that moves in and out of the lungs during normal inhalation, exhalation. The total lung capacity is really the total volume of the lungs, sum of vital capacity and the residual volume. When you talk about the inspiratory reserve volume, IRV, that's the maximum amount of air that can be forcefully inhaled after a normal inhalation. So IRV is really VC minus EC. We've talked about what EC is. What's VC? Well, we'll get to that in a second. Inspiratory capacity is the maximum volume of air that can be forcefully inhaled after a normal exhalation. So IC would be tidal volume plus IRV. The functional residual capacity, FRC, is the volume of air remaining in the lungs after normal expiration. So FRC is equal to the residual volume plus the EV. Residual volume is the amount of air that remains in the lungs after the most forceful expiration. Here's the key point. Look, this is you just sitting there relaxed. This is your tidal volume. Inhale, exhale, inhale, exhale. Now, after you finished on your exhale, then you force more out, and that's the ERV. Come back, inhale, exhale. And as you start to inhale, you're told, bring it in more. And that is going to be what you see, your inspiratory capacity, which really is part of the IRV plus your TV, or in this diagram, they say it VT, okay? The total lung capacity is really the amount from the minimal volume, the residual volume, or includes the residual volume, as well as everything else, so the vital capacity here. Why do we call it the vital capacity? This is mostly what you're looking for when you force it out or you force it in, as well as when you normally breathe. After you normally breathe, functional residual capacity, FRC, is basically everything down here. Now, there are differences between males and females. Now, before you get concerned, I'm not going to ask you to memorize this, okay? Just to understand the basics. In tidal volume, they're about the same. But when we have the IRV or EV, we'll notice some differences. Now, the reason in part is because of the tissue buildup that occurs and the metabolic demands that occur more with the males. Okay? That's all I want you to really recognize right now. Pulmonary ventilation must be closely regulated to meet the tissue oxygen demands. Okay? The respiratory rate is defined as F. That's the respiratory frequency. So in other words, the number of breaths taken each minute. The respiratory minute volume, that's the amount of air that moves in and out of the lungs per minute during a normal inhalation, exhalation. So really what it is the tidal volume. Now in this case, they put it as VT, but it should be TV, times the number of breaths, and that gives you this VE, minute volume. The alveolar ventilation is the amount of air that enters the alveolar pathways each minute. So the VA is equal to F times tidal volume minus VD. Now what is VD? That's anatomical dead space. That's the volume of air that remains in the conducting airways and never enters the alveoli. In other words, if you take even what they call a sheep pluck, which is basically the lungs of a sheep that have been taken from an abattoir, and you squeeze down all the air so you could try to get it out of the alveoli, there's still going to be air occupying some of the bronchi, bronchioles, etc. That's anatomical dead space. Here we see tidal volume. You see going from inhalation to exhalation, inhalation to exhalation. And basically what you're saying is how much in a full breath, tidal volume, about 4 seconds here. Here's the mathematics. And as you remember that VT, that was, I called it TV, tidal volume, but the book at that point said VT. So here's the amount of air moved each minute. VE times the number of respirations a minute times the tidal volume. And you can see how much is going on there. Now this is when you're just at rest, and this is the amount of air you move each minute. Keep in mind that the air in the conducting portion of the respiratory system is the anatomical dead space. So that's all the air that occupies these reddish areas here, as opposed to the blue, which is the air in the alveoli. And of course, we had the anatomical dead space. That can be derived from tidal volume times 0.3. So if you say your tidal volume is 500 milliliters, and you take that 0.3, you really have an anatomical dead space of 150 mils. And then you can do these other mathematical equations. Now, you don't have to worry that much. I'm not going to demand too much on mathematical equations. I do want you to understand the principles around this, including a respiratory minute volume and alveolar ventilation. We got two more laws here that you do need to be familiar with. Okay, first one is called first one deals with the principle around partial pressure. Now, what you have to understand is that gas diffusion depends on the partial pressures and solubilities of the gases. First off, when I talk about partial pressure, I added up all the pressure of the atmosphere right now, and I added it up by the different types of gases. So 78% of that pressure is from nitrogen. 21% of that pressure is contributed by oxygen. We'll say 0.1% is contributed by water vapor, and going on and on and on and on. And it was Dalton that came up with this law that said basically the law of partial pressures, which he says the pressure total is equal to the pressure 1, pressure 2, pressure 3, whatever. So in other words, what he's saying is, if you think about it, if oxygen is only contributing about 21% of the atmospheric pressure. So if you say atmospheric pressure is 760 millimeters of mercury, only 21% of that is really from oxygen. Now this has an immediate concept or importance if you talk about somebody that goes through hyperbaric chambers, because instead of 1 atmosphere pressure, we put somebody into a chamber and put them into 3 atmospheres pressure. So that's 3 times 760. 3 times 760 is a certain amount. I'm not going to play the numbers right now, but then if you take into that much larger amount times just 21%, you have a much larger partial pressure of oxygen. And why we favor hyperbaric chambers in some cases is to get oxygen at a much higher pressure rate into tissues that are much more difficult. Burn victims, individuals that have the bends, where they have basically nitrogen bubbles that have solubilized and started forming in tissues, particularly like serous membranes, the joints, etc. And you can try to resolubilize those under a greater atmospheric pressure and then get them breathe out and basically remove those pressures. Hyperbaric chambers are beginning to get very, very common, and they're used for a variety of other applications aside of things like the bends. Okay, that's one. Now let's talk about Henry's law. That's the amount of a particular gas in solution is directly proportional to the partial pressure of that gas. Take a soda can, for example. Now, in a soda can, you have to think about this. There's a certain amount of carbon dioxide that's solubilized, dissolved in the liquid, okay? And part of that is dependent on the gas that is above that liquid level in that sealed can. Now, when you pull the pop top off, what are you hearing? One, as you pull the opening, the gas that is pressurized above that liquid leaves. It drops down in pressure, and the gas that is dissolved in the liquid, because it was at a higher pressure, it was staying in that liquid. And now what happens is you have the bubbles coming out because the gas above the liquid has been reduced, and therefore the solubility of the carbon dioxide gas in the soda has now decreased, and therefore the excess will be driven out in the form of gas bubbles. Okay? Is this important? Absolutely. Because solubilities and partial pressures drive gas exchange from higher concentrations, that is pressure, to lower concentrations, that is pressure. Okay? So, if you look at the atmospheric pressure, 760 millimeters of mercury, and do what Dalton's law says, you have 597 partial pressure, in other words, millimeters of mercury, partial pressure of nitrogen, 159 partial pressure of oxygen, 0.3 partial pressure of CO2, 3.7 partial pressure of H2O, 760. Now, there are differences between your sample. Inhaled air, you're going to see the differences in nitrogen, oxygen, carbon dioxide, water vapor. In alveolar air, that's saturated, so you're going to have a decrease in nitrogen, a decrease in oxygen, an increase in carbon dioxide, and an increase in water vapor. You've got to moisturize that air a lot better. When you exhale the air, this is where it is saturated. Notice that you're going to have a lower amount of nitrogen. You're going to have a slightly elevated amount of oxygen. You're going to definitely have a greater amount of carbon dioxide. And you will also have that certain amount of water vapor, which I kind of mentioned before. You know, when you breathe out air, it's going to be much more richer in water vapor, and thereby you're going to have those, on really cold days, that appears breathing out moisture, almost like a fog. Now, Henry's law. Under pressure, gas molecules are forced into solution until the equilibrium is reached. So if I put more pressure down on this, I can drive some of these gas molecules into this liquid until you get an equilibrium where number of molecules leaving equals number of molecules entering. Soda can is a perfect example. But suddenly, if you look at the lower one, I decrease my pressure. The partial pressure is decreased. The gas molecules are going to come out of solution. Boom. And eventually you have a new equilibrium that will be released. Open the soda can, you get psh. The gas pressure here will drop as the gas pressure here drops. The gas is dissolved in this liquid will also decrease. Certain amount of the gas will escape in the form of gas, carbon dioxide bubbles. Now, how does this play to physiology? I knew you were waiting. I knew you were just kind of like, so what? This is how it plays a role. Think about it this way. Partial pressure is the same as saying concentration, okay? All right. So you're going to always go from an area of high concentration to an area of low concentration. Let's look at the pulmonary circuit first. In external respiration, you have the blood coming in to this gas exchange here, the blood-air barrier. Oxygen is at 40, carbon dioxide is at 45. In the alveolus, the oxygen level is much higher at 100. The PCO2 is at 40. Greater amount of carbon dioxide, so it's going to go from here to the alveolus. So pulmonary capillary to the alveolus. There is a much greater amount of oxygen in the alveolus, and it will go into the blood. And as you can see, the oxygen level, and I believe that's a typo, because it should be in a much higher amount, the pulmonary capillary. And what happens is the PCO2 should drop also, okay? Because you're going to get this oxygenate. Now, if you look at internal respiration. The oxygen level here is much lower, 40. The oxygen level in the blood is at 95. The carbon dioxide in the tissue is at 45. The carbon dioxide in blood is at 40. We have a gas exchange here. We're going to go from higher quantity to lower quantity, and higher quantity to lower quantity. So eventually you have the oxygen at 40, the PCO2 at 45. Okay? Now, very important point too. Almost all of the oxygen in blood is transported bound to the hemoglobin with the red blood cells, okay? So transport for oxygen is going to be found to be different than the transport of carbon dioxide. I want you to understand that. Because the oxygen solubility in plasma is low. The oxygen solubility in hemoglobin is very high. That's where we get into what we call oxyhemoglobin. The hemoglobin saturation, that is the percentage of heme units containing bound oxygen molecules. That's a measure. When we talk about oxygen hemoglobin saturation curve, this is the graph that demonstrates the saturation of hemoglobin at different partial pressures of oxygen. Okay? You want to keep in mind also, blood pH and temperature have a direct effect on oxygen hemoglobin saturation curve. This is referred to as the Bohr effect. So it's the effect of pH on oxygen hemoglobin saturation. Carbon dioxide is primarily responsible for this effect. Remember that we talked about hemoglobin composed of two beta subunits, two alpha subunits. Each subunit, both alpha and beta, have a heme group here, which in the center of it consists of an iron ion. Now, where the slope is steep, there's a very small change in blood PCO2 will result in very large changes in the amount of oxygen bound to hemoglobin or released from oxyhemoglobin. Okay, so here's what we've got. Here is our partial pressure of oxygen. Here is the percentage of saturation of oxyhemoglobin. Okay, so if we take a look here at the partial pressure of oxygen in active muscle tissue, it's fairly low because active muscle tissue are constantly using up that oxygen. But just move over from here to here, you see the average partial pressure of oxygen of blood leaving peripheral tissues. We go over to here, this is the average PO2 of blood entering the systemic circuit. So this is where oxygen has been heavily oxygenated and it's leaving the aorta and it's on its way to the rest of the tissues. And if you go backwards, you go to the areas leaving peripheral tissues. It's significant, but not completely lowest. But with active muscle tissue, this is really, really taken a lot away. Now, one of the other things that happens is the curve shifts. It's going to shift right with decreasing pH, and hemoglobin releases more oxygen. Now, why would you get a decreasing pH? Oh, yes, if you remember ANP1, when you have situations with rapidly metabolizing, rapidly active, very, very active muscular tissue, you're going to eventually start releasing lactic acid. And lactic acid is going to release, it's going to affect the blood pH in such a way you're going to go negative. So if I'm up here, I'm going to have the shifts left with increasing pH, and the hemoglobin releases less oxygen, sort of like monitoring itself. But when I start getting more acidic, it's going to be much more rapid in its release. Okay? And it only makes sense. You're having the buildup of lactic acid. You've got to be able to deliver that oxygen because it's clear that you're moving from aerobic to anaerobic, having a buildup of lactic acid. it is going to alter the pH, and so this is a homeostatic mechanism that allows you to adjust for pH by releasing more oxygen in the tissues that are metabolically active and needed. And you can see this also with temperature. As the body builds up in temperature, and that can happen, such as the buildup of heat, etc., you're going to have a much more vigorous amount of release of oxygen. If it gets colder and colder, you will note that the body is not going to release as quickly the amount of oxygen necessary. And the reason being is that with less heat, that means less metabolism, and less metabolism means less requirement of oxygen. Carbon dioxide is transported in 3 ways in the bloodstream. Carbon dioxide transport mechanisms: you have it dissolved in the plasma, you have it bound to hemoglobin within the red blood cell. So there's lots of hemoglobin inside that RBC. It's going to be bound to the various amino acid structures that make up hemoglobin. And then it's converted to bicarbonate ion, which is HCO3, -3 actually, within the red blood cell. Now, all of these reactions are reversible. Carbaminohemoglobin, that is referred to as HbCO2. Hydrogen ions bind to hemoglobin, that's HbH+. Now, you would have that occurring if you have the dissociation. Remember that we talked about this a while back. Carbon dioxide plus water gives you carbonic acid. Carbonic acid will break down to hydrogen ions and bicarbonate ions. The enzyme that allows CO2 to be converted to carbonic acid or speeds up the rate is carbonic anhydrase. Okay? So, with the movement of carbon dioxide into forming bicarbonate ions, you have these bicarbonate ions are pumped into the plasma from the red blood cells via countertransport of chloride ions. This is part and parcel of what we call a chloride shift. The chloride ions are transported inward, the bicarbonate ions are transported outward. Here we have carbon dioxide diffusing into the bloodstream. 93% diffuses into the red blood cells, 7% remains in solution. Of that, 23% is bound to hemoglobin as carbaminohemoglobin. 70%, or about that, is converted to carbonic acid by the activity of the enzyme carbonic anhydrase. The carbonic acid molecules immediately dissociate into hydrogen ions and bicarbonate ions. The hydrogen ions will bind to the hemoglobin, forming hemoglobin hydrogen ions. In the other amount, you're going to have a lot of bicarbonate ions, and what happens there is now you have this exchange occurring. This is part of the chloride shift. You're going to have a antiport system, which is a pump here. Bicarbonate ions get pumped out. They're negative charge. Chloride ions get pumped in. And you can see what's happening here in this diagram for oxygen pickup and oxygen delivery. This is basically the external respiration. Here's the internal respiration. So you're in the pulmonary capillary here. You pick up oxygen. Oxygen binds to hemoglobin. Nicely done. Here, you're going to deliver oxygen to actively metabolic tissues, the peripheral tissues. Hemoglobin with oxygen. The hemoglobin is going to release the oxygen, and it gets basically directed right out of the capillary into the metabolic tissue because the oxygen concentration here is much lower than what's in here. Carbon dioxide transport. When we deliver carbon dioxide into the alveoli, the partial pressure of carbon dioxide in the alveolar airspace is much lower than it is in the cell. The partial pressure of carbon dioxide in the blood is 45. So what's going to happen is you're going to have this reversal here. You're going to have first bicarbonate brought in, chloride pumped out. You will have the hemoglobin that binds to the hydrogen ion, freeing up the hydrogen. Hydrogen plus bicarbonate gives you carbonic acid, which then gets converted to carbon dioxide. The water stays where it's needed to, and well, you have carboxyamino hemoglobin here. Hemoglobin dumps off the carbon dioxide. All of it heads out. And as it heads out, including the small amount that's solubilized in the plasma, you're going to go from 45 here to 40 there. Now, what about picking up in the systemic capillary? Well, the partial pressure of carbon dioxide in the tissues is 45 millimeters of mercury, so it's greater here. It's going to get picked up because in the blood here, the partial pressure of carbon dioxide is originally 40, goes up to 45 as you pick up the carbon dioxide. Some of it will be solubilized in the plasma. Some of it will get processed and formed into amino hemoglobin. Some of it will mix with water. You will have a dissociation. You'll end up with hemoglobin containing the hydrogen ions, and the bicarbonate ions will be kicked out. Chlorides brought in during the chloride shift. Pulmonary disease. Let's take a look at this. This can affect both lung elasticity and airflow. When we talk about compliance, this is the measure of the expandability of the lungs. Resistance for lungs is an indication of the amount of force required to inflate or deflate the lungs. In respiratory distress syndrome, this is due to inadequate surfactant production, which I mentioned earlier. It leads to alveolar collapse on exhalation. And so here we have the compliance here. If we have normal lung compliance, no real problems. You will have situations where you have arthritis or other skeletal disorders that affect articulations of the ribs and spinal column, which will reduce the compliance by reducing the elasticity of the chest wall. That's where you can have sometimes the respiratory distress syndrome. If you have loss of supporting tissues and destruction of the alveoli, they're going to increase compliance. The greater the compliance, the lower the tension of the walls of the lungs at a given volume. Now, resistance, what about this? Well, remember, resistance is equal to inflation force, okay? Sympathetic activation of bronchodilation reduces the resistance. So, the lower the resistance, the more easily air will flow through the conducting passageways. Okay. If I have bronchoconstriction, though, that's going to increase resistance. Now, this can occur because of excessive mucus production or airway inflammation, such as what you would see with certain situations, anaphylaxis, asthma, etc. So the higher the resistance, the harder it is to force air along the conducting passages. Now let's start dealing with some of the particular terms that we hear from time to time and the particular disorders. Chronic obstructive pulmonary disease. This is a general term. We also refer to it as COPD. This is a progressive disorder of the airways that restricts airflow and reduces alveolar ventilation. One condition, asthma, is characterized by conducting passageways that are extremely sensitive to irritation. Okay, this can occur in the young or occur in the older persons as well. The airway response occurs, and basically you have the constricting of the smooth muscles all along the bronchial tree. So if you have constriction, you have reduced flow. The greater the constriction, which means the lower the amount of the lumen diameter, the lower the flow is going to occur of air, right? The triggers for asthma include allergies, toxins, even exercise. One interesting paper I remember reading some years back from a nursing paper, they basically they noted that there were patients who had asthma after a thunderstorm. And somebody was wondering, well, what does it got to do with a thunderstorm? Simple. Thunderstorms usually cause downdrafts of air as well as updrafts of air. And so what's literally possible is to have this massive amount of wind moving around allergens, pollen, and dust. And this would be the triggers for asthma attacks. Chronic bronchitis. This is a long-term inflammation and swelling of the bronchial lining leading to mucus overproduction. One of the signs is frequent coughing with copious sputum production. This can lead to cyanosis. Now, cyanosis is a person takes on a kind of a bluish color. They don't have sufficient oxygenation to certain tissues. As a result, they're called blue bloaters. They are characteristic with having some edema, as well as bluish coloration in certain parts of the face. Emphysema. This is a chronic progressive condition characterized by shortness of breath and an inability to tolerate physical exertion. The exaggerated respiratory movements cause the skin of pale-skinned patients to appear pink. A combination of heavy breathing and pink coloration ends up calling these individuals pink puffers. Here we have a child with asthma, and you can see that they're taking an inhaler, which will cause a bronchodilation to enhance their breathing. Here is a chronic bronchitis patient. Here is emphysema, and you can see the density of the tissues here are somewhat reduced because of the breakdown of some of the alveolar spaces. Now, we want to also cover the neural mechanisms that control breathing. These basically involve interacting centers in the brainstem. Now, you have to keep in mind, though, that there are some higher centers, such as the hypothalamus, limbic system, and cerebral cortex, that can alter the activity of lower brain centers. Now, there is an apnoistic and a pneumotactic center that are located in the pons and adjust the output of respiratory rhythmicity centers. The respiratory rhythmicity centers are located in the medulla. Don't get them mixed up now. Okay. The dorsal respiratory group, DRG, is concerned with inspiration and modifies activities in response to input from chemoreceptors, which monitor oxygen, carbon dioxide, and pH in the blood, and cerebrospinal fluid, as well as you're going to have also baroreceptors. These are stretch receptors in the walls of the lung. So all of this information is feeding in to the DRG. The ventral respiratory group, VRG, is primarily concerned with expiration. And then we have in the ventrolateral medulla a basic pattern generator. It's also been referred to as the pre-Botzinger complex. Now, if you think about basic patterns, so is this the one that kind of handles to a degree tidal volume? Yeah, because there you don't have to think about it. With a lot of the automatic systems, you never think about it. You don't tell yourself, breathe in, breathe out, breathe in, breathe out. It just is occurring automatically. Here we have the higher centers, including the cerebral cortex, limbic system, hypothalamus. Then we have the pneumotactic centers, as you can see, are located in the pons, including the apnoistic center. Now, these will adjust the output of the respiratory rhythmicity center. The rhythmicity centers are going to be located in the medulla oblongata. We have the pre-Botzinger complex. We have the inspiratory center at the dorsal respiratory group, which is right here, DRG. The DRG will also play a role and interact with the ventral respiratory group. Okay? Basically, the VRG acts on the accessory inspiratory muscles and the accessory expiratory muscles. So VRG plays a role in both the inspiratory and the expiratory centers. In quiet breathing, look at that's what, about 2 seconds, maybe 5 seconds total. Okay, so the diaphragm, external muscles relax and passive exhalation occurs. The activity of the DRG stimulates the inspiratory muscles, so diaphragm, external intercostals contact, contract and inhalation occurs. Neurons of the DRG become inactive. They remain quiet for the next 3 seconds, allow their inspiratory muscles to relax. Okay, that's inhalation. Forced breathing, though, and remember we talked about what muscles play a role there. Let's start here. After each inhalation, the active exhalation occurs as the neurons of the expiratory center of the VRG stimulate appropriate accessory muscles. Inspiratory muscles relax. So you have increased activity of DRG stimulates the neurons of the VRG that in turn activate the accessory muscles involved with inhalation. Expiratory center of the VRG is inhibited. Inspiratory muscles contract, expiratory muscles relax, inhalation occurs. DRG and inspiratory center of the VRG are inhibited. Expiratory center of VRG is active. So what am I saying here? You're going to have this seesawing effect so that one nucleus is not overseeing all activities, but it's a seesawing effect. In quiet breathing, it's mostly DRG. In forced breathing, you have DRG interacting with the VRG to make sure that you have more forceful breathing in and out for the oxygen demands, the gas demands of the body. So the stimuli that trigger respiratory reflexes, chemoreceptors I've talked about, baroreceptors I've talked about, stretch receptors, they respond to changes in the volume of the lungs that are responsible for inflation and deflation. Because here's part of the point. How is it that I don't have the capability to completely, and almost like a balloon, continue to keep filling up until I burst? Well, yes, you have the structural limits that exist with the chest volume controlled by the ribs, controlled by the muscles, etc. But you also have the neural limits too. Now you also can have irritating physical and chemical stimuli to the nasal cavity, to the larynx and bronchial tree, providing protective reflexes. This is where we get coughing and sneezing. Okay, so let's talk about a couple of other activities here, some other topics. Respiratory reflexes provide rapid automatic adjustments in pulmonary ventilation. We've talked about the brain system that controls it. Let's also talk about some of the other aspects of this. When we talk about hypercapnia, this is the increase in arterial blood PCO2. Common cause, hypoventilation. Hypocapnia is abnormally low PCO2. Common cause, hyperventilation. You probably see when somebody is having this sort of panic attack, they're breathing fast, breathing fast, breathing fast. And the rate and the depth of the respiration exceeds the demands for oxygen delivery and CO2 removal. This is where we can also have situations where somebody tries to do lots of breathing really quickly and then tries to go into water. This is called the shallow water blackout. The swimmer initiates hypocapnia and it leads to unconsciousness due to oxygen starvation. Now, the inflation and deflation reflexes, they're activated by lung stretch receptors. The inflation reflex prevents overexpansion of the lungs during forced breathing, which is one of the things I mentioned earlier. The deflation reflex inhibits the expiratory centers, stimulates the inspiratory centers when the lungs are deflating. By the way, here's another sidebar for one little interesting thing. How is it, when you see these situations when the magician submerges himself wrapped in chains and he's underwater? Well, how is it that someone who gets fed to the fishes, basically they will bind them up and toss them into the water, how long can they hold their breath? Not too long. You see, even though you keep telling yourself, hold your breath, hold your breath, hold your breath, control it, hold your breath, you eventually will have the neurological triggers that will say, inhale. And unfortunately, what you're inhaling is not air, but water. That's why in autopsies, they can also tell the difference between when someone has drowned or someone was dead before they drowned, because one of the ways to determine that is whether they would find water in the lungs, particularly deep down in the alveoli, because the person just did this massive breath in. If they're dead, they're not going to have gas exchange. Same thing as if someone was in a smoke-filled room. They're in a fire. Were they killed before the fire? Or did they inhale? If they inhaled, they would have smoke particles laid out deep into the bronchial tree, even into the alveoli. This is all neural pathways, and eventually they overtake the cerebral cortex, the executive function, where you're saying, don't breathe, don't breathe, don't inhale, don't inhale. Now, there are some protective reflexes which we've mentioned before. These are reflexes that are triggered when exposed to irritants, and they include sneezing and coughing. Apnea. This is a period of cessation of breathing. One of the common things that happens for some people with sleep disorders is sleep apnea, which means that the person has for a period of time, they will stop breathing. This is not good, obviously. Usually what happens when one has sleep apnea is they have such a disruption, they wake up, or they have a disruption, they will start breathing again, but this will prevent them for the necessary quality of sleep. They will rarely get into REM sleep. It will also be a stressor to cardiovascular system. So usually when you have someone who's older, they can be younger, they can be overweight, they can be normal body mass, but when they have these cessation events, this will disrupt the sleep and they will not be as well rested. The brain will not be as well stabilized because it hasn't had the REM sleep that's necessary. In looking at homeostasis, if we were going to talk about normal arterial PCO2, if we have hypercapnia, the increasing amount, we would go through the receptors, the effectors, which would be the respiratory muscles, to increase the respiratory rate to cause a decrease in the arterial PCO2. If we had the opposite to achieve, re-establish normal arterial PCO2, and we had hypocapnia, then what we would do is have inhibition. The information would be passed on from the chemoreceptors, respiratory muscles would be inhibited, and you have the decreased respiratory rate with the decreased elimination of CO2 until you achieve a more stabilized amount of CO2 in the arterial blood. Keep in mind, arterial blood pressure and respiratory minute volume, there's a certain fixed rate that allows for stability of function. Keep in mind that you have stretch receptors that play a role in feeding information about the function and the status of respiratory muscles, and these can be inhibited by the respiratory rhythmicity centers, and inhalation can stop. This is where we talk about VRG and DRG and VRG. Now, what about when you want to sneeze? Well, this is when you get stretch receptors located in the alveolar walls. They're stimulated. The elastic fibers recoil, the alveolar volume is reduced, and you build up a tremendous amount of pressure to force out. The forced inhalation now begins with activation of DRG, the inspiratory center of VRG. The expiratory centers of VRG are inhibited. The inhibition continues until exhalation stops. Now, in the other situation here is that you see with the sneezing man, what you have is a reversal, and it's very quick. It's more a response. And you can breathe out, and you can see how that particles of an aerosol are generated. Respiratory function decreases with age. Smoking only makes matters worse. Elastic tissue will deteriorate. Vital capacity decreases. These are all factors that occur as we begin to get older. Rib joints can stiffen due to arthritis. And then we have to deal with the issues about lung cancer, which is an aggressive cancer that can affect the epithelial cells of passageways, mucus glands, and alveoli. When we talk about something as metastasis, that's the cancer cell has migrated from the original site of the formation of the tumor, and some of the cells have moved on to other areas. Cigarette smoke, or cigar smoke, or vaping, or cooking smoke, etc., can be an irritant. What happens with normal cells, as I mentioned before, that some of the particles and chemicals in the smoke can paralyze ciliary movement. Dysplasia is cell damage and functional structural changes to these cells. It has not gone cancerous yet. It is when you get into metaplasia that tissue changes in the structure in response to injury or chemical stresses occurs. And eventually from there you move into neoplasia, which is the growth of abnormal cells to form cancerous tumors, a neoplasm. Anaplasia is when the cells become malignant and have metastasized, spread. This state is not reversible. So I want to go over some of these basics as we come up to the conclusion of our respiratory system chapter. If you look at the respiratory performance, that's the percentage of value at age 25. As you move from 25 here and here, you start having this decline. Now, notice that the decline is much more gentler in a slope, even to the point of 75. But if you're a regular smoker, that decline begins to really increase in its slope and accelerate. If you notice that you're at age 50, you're far lower than if you had never smoked. You also note that by the time you get to about 75, you're at death. If you've stopped at age 45, you can still have this return to a gentle slope, but it can never reestablish what performance you have if you had never smoked. Notice if you've stopped at 65, you may have some reduction in the loss proportion. The slope declines a little, but it's not the same. Interestingly enough, on average, if you put an estimate of that being about 60 is when you start getting into disability, okay, as a result of the smoking. Here is a normal lung. Here is a lung cancer. Notice that there are various tumors that have set in, as well as deterioration of the size and performance of the tissue in the lung. Here's a major cancer here. And the process of smoking, you have to keep in mind that in the smoke, you will have carcinogens, chemicals that are in the smoke. As I said, you have a failure or a paralysis during the exposure of the cilia. So the chemicals may deposit into the mucus, but then may come in contact with the cells. They may lead to damaging of the cells. This is the dysplasia. Note that from normal respiratory epithelium through metaplasia, there is a reversibility. But once you get to metaplasia, the movement down to neoplasia and anaplasia, the process is not reversible. Okay? So as you can see here, here's still your goblet cells and the other cells. These are damaged. Some of the damages will now be assimilated and alter the structure and performance of these cells. And eventually they will lead to uncontrolled growth, which is where you have neoplasm. Anaplasma is basically where the cells have started to not only breach their limits of their cell lining, but they will begin to migrate and lead to the formation of secondary and tertiary tumors. Well, that's pretty much our chapter. I would encourage you to peruse chapter review outline on pages 833 to 835. To complete the review questions, you want to take the time to review 836 and 837. Complete review sheets on 810 and 832. Also, don't forget that I've set up a series of videos to help you to review the content for the respiratory system. The next chapter that we will go into is chapter 22 on the digestive system. And have a good day.